Good morning, and I am the pathologist who you never see, but I see all of you pretty much every day through my microscope. But it's still an honor and privilege to be here and actually see a lot of you in person, and I hope to kind of emphasize what we do as part of taking care of your diseases. So basically, I wanted to cover a little bit about the technical issues. Sometimes you wonder if doctor took out a biopsy from you and you don't have the results for a week, what's going on, why is the delay, and so on and so forth. And how do we make a diagnosis, and why is margin status important, and why should we examine those margins? Prognostic factors, that's how we contribute to the care of patients with melanoma. And what we do and what we put in a report is so important in staging, basically telling you, telling a patient what the status is, what the prognosis is, good, bad, in between. And based on the report that we issue, the surgical oncologist will actually determine what kind of additional treatment you might need, and how we are involved throughout the care of patients with melanoma during follow-up, during extraordinary therapies and clinical trials. So Dr. Rhodes covered how screening and early detection is very important. Even with the best of the techniques that he uses, he still has a differential diagnosis of 2 or 3 entities. At least one of them is melanoma, but 2 others are benign lesions. And therefore, he will actually have to take a biopsy and send it to us, and us meaning a pathologist. And who is a pathologist? Pathologist is actually a medical doctor. Dr. Kaufman mentioned we are doctors, and we have special training in examining tissues. That's our focus. That means medical school plus 5 years of residency training, and that's what we are about. And who is a dermatopathologist? Somebody with additional training who actually wants to look at only skin biopsies or skin excisions, and that's the focus. And that's what I did. I have an extra 1 year of training to do just that. And whenever I get a suspicious lesion, what am I looking for? The first and the foremost important thing, is it melanoma or is it something else? So Dr. Turnham mentioned about the melanoma, where it comes from and all that. Pathologists are very visual people. We like pictures better than talk. And this is basically what it shows. This is our skin. Yeah, that's the skin. And this is the outermost layer of skin, that's the epidermis, and this is rest of the skin, that's called dermis. This is a melanocyte, and that's the source of the pigmentation that we see on everybody's skin. Everybody has about the same number of melanocytes. Believe it or not, dark-skinned person like me have the same number of melanocytes as somebody with lighter skin, except mine makes more pigment than yours, that's all. But this is a cell that's the source of melanoma, and that's what we are seeing here. So pathologic diagnosis of melanoma, it begins in a clinician's office, and Dr. Rhodes mentioned all the screening techniques and how he would identify a suspicious lesion. And once he identifies that suspicious lesion, he's going to excise, and he's going to send it to a pathologist to read. There are several different types of biopsies one could do. Ideally, we would like to see an excisional biopsy where the entire pigmented lesion is taken out with little bit of normal skin on all sides, so that we can establish whether the margins meaning normal tissue around the tumor, is clean or uninvolved or not. And a good specimen allows us to make better assessment and more accurate diagnosis. So that's a key. I know there are certain locations where you don't want too much skin taken out, and that's perfectly understandable, but to the extent possible, the entire suspicious lesion with some clean skin all around should be taken out. And once we get it, there's a process that the specimen goes through. A pathology resident or a pathology assistant will look at the specimen and make certain assessments, and we process the tissue, we make glass slides, and sometimes we don't see too much on the first blush. When we put the slide under the microscope, we might have to cut deeper sections, which is called step sectioning, and sometimes we resort to special stains, which might actually take another day or 2 for us to issue a diagnosis. So that's where the delay comes from in some cases. So this is our resident, basically got the specimen here, and processing here, and we look at the specimen measurements, ink the margins, and this is a schematic. Here is a pigmented lesion, basically inking the margins, and that's normal skin. But under the microscope, what looks normal may not always be normal. So that's one thing we keep in mind, and that's what we are going to look for. And here is an excision of a pigmented lesion being sectioned. We put it in the cassette. That's a plastic container that will take the specimen. And it goes through a routine, series of processing. We call it processing. And then at the end of it, the specimen is embedded in wax. That's called paraffin. And once it's embedded in paraffin, a technician cuts the slides. And the initial sections have no color in them, so we cannot see through the microscope and make any diagnosis. So we add some colors to it, and the end product looks like something like this. And these are the slides we get, and this is the point where we actually require a microscope to look at these sections under the microscope to make the diagnosis of melanoma. Yeah. Okay. So clinically suspicious moles, Dr. Rhodes talked about it, and this is not a problem, and he will identify the appropriate specimen that he needs to take and that needs more workup at looking at through the microscope and making a diagnosis. But okay. Okay, but oftentimes there are masqueraders, there are mimickers, and a pigmented lesion that looks like this on this side of this patient and something like looks like this, both look almost the same to my untrained eye, and one of them is completely benign seborrheic keratosis and one of them is a melanoma. And that's why I think pathology is important. That's why pathologists get to make the final diagnosis in all these cases. And Dr. Rhodes also mentioned about the amelanotic melanoma, totally unpigmented, looks like nothing, and even clinicians might think that this is basal cell carcinoma or something else, needs to be excised and looked at under the microscope. So once we get the specimen, once we get the slides, we look at it through the microscope, and the first order of business is to decide whether the lesion represents a benign condition or a malignant condition. If it's benign, it's a nevus, it's a seborrheic keratosis, completely benign, no problem. But if it's malignant, and usually it's malignant melanoma, we have to decide whether it is in situ, meaning it's confined to the outermost layer of the skin, so it's completely curable, or is it invasive. And this is a schematic. I tried to not to bring too many glass slide pictures because I thought I should stay away from those. Dr. Rhodes had more images of that than I am going to show you. So this is a schematic. This is a pigmented lesion. This is actually a few millimeters in thickness, even though it looks so big on the screen. And this abnormal area is the one that we are looking at, and this is that basement membrane. This is the upper part of the epidermis. If the melanocytes are spreading like this within the epidermis, but have not broken through that very thick layer, it's called basement membrane. If it does not invade this part of the skin, this has an excellent prognosis. And that's what we call melanoma in situ, which is a very stage 0, totally curable, no problem. But once this basement membrane or this piece of collagen is broken down, the cells start to invade the dermis. And once they invade the dermis, they acquire this property or this capability to spread elsewhere. And the reason for that is in the epidermis, there are no blood vessels. So the cells can only spread along the epidermal layers, can't go anywhere else. But once they come into the dermis, though, there are large number of blood vessels here. The cells can enter the blood vessels, the lymphatics, and then they have the property or the capability to spread elsewhere. So that's a very important distinction that we have to make on the first blush, in situ versus invasive melanoma. And once we decide that it is an invasive melanoma, we issue a report, and our report will include large number of facts that your clinician will understand and use that to make further decisions as to how to take care of you. And one of them is levels, thickness, ulceration, mitosis, and if the margins are clear, the tumor is completely taken out or need to be re-excised. So levels, Clark levels, I only mentioned this, we don't use that anymore, but levels I mentioned because many patients confuse levels with stage. It's not the same. Stage is something your clinician will determine based on all the information that you have, whereas levels refer to the level of invasion in the skin. A better parameter for assessing that invasion is what we call Breslau's thickness or thickness, depth of invasion, all those terms mean the same. And basically we have a ruler in the microscope through the piece that we look through, and with that ruler we measure how far down has the melanoma spread down into the skin layers. And if it's early lesions are confined, that's the in situ. As we go, as the lesion progresses, it starts to go deeper and deeper into the dermis. And rather than say it invaded this part of the dermis or that part of the dermis, we just use an objective measure, a ruler, and measure the level of invasion. And that's a much better prognostic factor, and that's going to be part of caring for you. So, ulceration is another factor, and clinically, a lesion might look like this or like this, but under the microscope, there is ulceration or not. That's a very important fact to report on. And ulceration is not something the lesion would show clinically on your body, but under the microscope is a different story. Even the earliest stages of ulceration can only be identified through the microscope. And this is one of the few pictures that I have. That's the melanoma that's showing diffuse ulceration on top. The third factor that we have to report and that makes a big difference in the staging of melanoma is the mitotic index. This is one thing that I can only show you a microscopic picture. Basically, we are looking at these kind of things. I don't know if you appreciate something different about them or not, but the basic idea is mitotic index refers to the speed with which the tumor cells are dividing. The faster a tumor cell is dividing, the higher is its aggressive behavior. The slower it is, low mitotic index, low aggressiveness. So that's basically an indirect way of measuring how fast the tumor is growing. So in short, these are the three prognostic factors we have to report on. Thickness is most reliable feature reflecting the risk of spread. Is it confined to the skin or the local site, or has it gone elsewhere? That's the message that is going to be drawn from that factor. Ulceration, again, ulceration is an aggressive feature. If there is ulceration, risk of recurrence or the melanoma coming back at the same site is higher, and that is also used in deciding what kind of additional therapies one patient might get. Mitosis, they estimate the speed with which the tumor cells are dividing. The higher the mitotic index, the faster the tumor is growing, so the more aggressive the tumor is. And all these facts that I have reported on is used to stage the melanoma, and it's called TNM staging. T refers to tumor, and basically the thickness, ulceration, mitotic index. All those factors are put in there. It's almost like an algorithm that is developed, and the melanoma is graded as T1, T2, T3, or T4, and you will notice that the three features that I mentioned, which is thickness, ulceration, and mitosis, all those are incorporated into the staging system. And that T is the most important part. T refers to primary cutaneous melanoma, the facts that we assessed under the microscope regarding your primary lesion, that's the key, and that is used to stage the melanoma. And again, staging is different from Clark levels. Forget the levels. Stage is the one that matters the most in planning your treatment and prognosis. Stage 3 and 4, pathologist is still involved. Stage 3 refers to lymph node metastasis present or not, and lymph nodes are excised, sent to us. Again, we do the same thing, process them, make glass slides, do special stains and look at them under the microscope and decide whether the lymph node is positive or negative. In stage 4, it's the same thing. If it's a distant organ involvement, if a biopsy is taken, we look at it under the microscope and say whether there is metastasis or spread of melanoma beyond the skin and lymph nodes to other organs or not. And this is basically a lymph node showing melanoma involvement. And here we use some special stains to highlight those tumor cells to make a confirmatory diagnosis of metastatic melanoma involving the lymph node. So during follow-up, we still don't give up on our patients, even though you never see us, we are still involved. If there's a recurrence and that's excised, we still look at it. If there are any suspicious bumps in skin or subcutaneous tissue, we do a procedure called fine needle aspiration biopsy to give a diagnosis very quickly if there's melanoma or not. And during follow-up, if there are new lesions arise in distant organs, and they're also assessed by pathologists. And this is a technique I just wanted to emphasize a little bit. This is called fine needle aspiration biopsy. And here, usually a pathologist or even a clinician can do the same procedure. We put a needle the same needle that we use to draw blood from your veins, and the needle is put into the tumor or the mass or the bump, whatever you want to call. Take out a few cells, put on the slide, and put some color on it and diagnose. Look at it under the microscope, and we can render this diagnosis very quickly within 20 minutes sometimes, and that helps the clinician who is taking care of you to plan the further treatment most appropriately and most rapidly. And molecular techniques, you heard a lot about all the BRAF mutations and all those things. We are also involved in that. We are the ones who select the slide, identify the tumor, DNA is extracted, and it's checked in our molecular pathology lab whether the tumor shows the mutation or not. So even though patients don't see pathologists on a daily basis, we are involved in all steps of the care of a patient, starting from the diagnosis, confirming whether there is melanoma or not in a skin lesion that was taken out, and if there is melanoma, is that in situ melanoma or is it an invasive melanoma? And if it is invasive, we also give the information to your clinician how thick the melanoma is, whether there is ulceration, and what is the mitotic rate. And we also, our report is the guiding document for the surgical oncologist, whether you need a bilocal excision, whether the patient needs a sentinel node biopsy, and if the node is taken out, is it positive or is it negative, and so on. And in the follow-up stage, we are still involved diagnosing those bumps and lumps that appear in the course of disease process, and we are involved in molecular testing and helping you be placed in clinical trials for targeted therapies. And that's all I have. Thank you very much.